After studying this module, you shall be able to know what is anaphylactic death, its etiology, and the various risk factors related to it. Also the pathophysiology of anaphylaxis, as well as the postmortem diagnosis of anaphylactic death. Now let's understand what is anaphylaxis. Anaphylaxis is a rapid onset, potentially life-threatening systemic allergic reaction that can affect people of any age or sex. Anaphylaxis requires an immediate trip to the emergency department and invariably an injection of adrenaline or epinephrine. If anaphylaxis is not treated right away, it can lead to unconsciousness and eventually death. Acute allergic reaction is an uncommon but well recognized cause of sudden death. The incidence of fatal outcome is not known precisely, but it has been estimated in the range of 1% of the total incidences of anaphylaxis per year. The reasons for the possible underdiagnosis is that in the humans, fatal anaphylaxis is difficult to study because it's rare, unpredictable, and often unwitnessed. Fatal anaphylaxis may be underdiagnosed because of the absence of specific findings at autopsy and lack of definitive diagnostic laboratory tests. Now, let's understand the etiology of anaphylaxis. The fatal anaphylaxis can occur following a variety of triggers, although the most common culprits are medications, food, and insect stings or insect bites. Approximately 1/2 of all anaphylactic fatalities each year in the UK register have been attributed to the medications or agents administered during medical procedures such as contrast media. Reactions to food and insect venom each accounted for nearly 1/4 of the total cases, with other causes accounting for the remaining cases. Let's understand what are those common ones. Medications. The beta-lactam antibiotics, for example, penicillin and cephalosporins, these two are the most important, and they appear to cause more fatalities than any other drugs. Multiple other agents such as radiocontrast agents, neuromuscular blockers, anesthetic agents, allergen immunotherapy, and other antibiotics have been implicated in small number of cases. The second important category is the foods. The peanuts and tree nuts, they account for the majority of food-induced fatalities. The cow's milk and seafood are also leading causes of severe and fatal reactions. A variety of other foods have been implicated less commonly. Then the insect stings. The stings of Hymenoptera species, that is the yellow jacket bees, honeybees, wasps, hornets, and imported fire ants. All these, they are one of the 3 leading causes of fatal anaphylaxis. Men are more often stung by insects because of their involvement in the outdoor activities. The other less common causes of anaphylaxis, fatal anaphylaxis, they include latex, rupture of a hydrated cyst, infestation with the Taenia solium, and dental impression material sometimes that it has been found. And in some cases, when no cause can be identified, the etiology is designated as idiopathic. Then there are several risk factors which are there to induce the anaphylaxis. The concomitant asthma is a significant risk factor for fatal anaphylaxis, particularly for adolescents with food allergy. The older victims of anaphylaxis often have underlying cardiopulmonary conditions. Other possible risk factors include delayed or no administration of epinephrine and upright posture during the anaphylactic attack. So that's why we advise that the person should be immediately lying down. He should not be straight. He should not be keeping straight. The epidemiology of anaphylaxis. The adolescents and young adults are at highest risk for fatal anaphylaxis induced by food. The middle-aged and the older adults account for most fatalities from the venom and medication-induced reactions, but there are no clear differences between various genders or among racial groups. Then coming on to the location of where these fatal anaphylaxis cases we encounter. Usually we see that fatal food reactions occur in the home of the patient himself, patient, or we can say the victim, the home of their friends, the restaurants where invariably they used to go for having the lunch or dinner food, the work or office settings, and schools. The fatal stings can be sustained outdoors more often than indoors. The medication-induced fatal anaphylaxis often occurs in a medically supervised setting. Then let's understand the timing and the allergen dose. The fatal anaphylaxis typically results in death within half hour to 1 hour of the ingestion or the exposure to allergen. So it's pretty fast. It seems logical that the higher the allergen dose, the more rapid and severe is the reaction. Although different patients may have different threshold levels beyond which they will experience anaphylaxis. The amount of allergen is usually unremarkable. For example, various amounts of food, one insect sting, a normal dose of medication, etc. Pathophysiology of anaphylaxis. The phenomena of anaphylaxis was first described in the modern literature early 19th century in a study involving protocols for immunizing dogs with the jellyfish toxin. The injection of small amounts of toxin in some animals rather than generating protection precipitated the rapid onset of fatal or near fatal symptoms. And the authors named this response as anaphylaxis, which is derived from the Greek word A stands for against and phylaxis stands for immunity or protection. So the anaphylaxis is a severe allergic reaction of rapid onset that occurs due to the release of inflammatory mediators and cytokines from mast cells and basophils, typically due to an immunologic reaction, but sometimes a non-immunologic mechanism can also play a role in that. Now let's understand what are those immunologic mechanisms. In this, there is the immunoglobulin E, that is IgE. This binds to the antigen. Antigen, that is the foreign material that provokes the allergic reaction. So this antigen bound IgE then activates FcRI receptors, which are situated on the mast cells and the basophils. And this leads to the release of inflammatory mediators such as histamine, tryptase, chymase, heparin, histamine releasing factor, and platelet activating factors. The cellular activation also stimulates the production of lipid derived mediators such as prostaglandins and leukotrienes. And these mediators subsequently increase the contraction of bronchial smooth muscles, trigger vasodilation, increase the leakage of fluid from the blood vessels, and can cause heart muscle depression. The non-immunologic mechanisms, they involve substances that directly cause the degranulation of mast cells and basophils. And these include agents such as contrast medium, the various preparations of opioids, the temperature hot or cold, and the vibrations. The organ system involvement in anaphylaxis, predominantly the shock organs are heart, lung, and vasculature, and the fatalities are divided between the circulatory collapse and the respiratory arrest. Now let's understand both these. In the cardiovascular system involvement, anaphylaxis is invariably associated with the myocardial depression, the arrhythmias, and subsequently the myocardial ischemia. The contributing factors include direct mediator effects on the myocardium, exacerbation of pre-existing myocardial insufficiency by the hemodynamic stress of anaphylaxis, and exogenous or endogenous epinephrine or adrenaline. The respiratory system involvement. Anaphylaxis may affect any part of the respiratory tract, causing bronchospasm and mucus plugging in the smaller airways and leading to laryngeal edema and asphyxiation in the upper airway. The asphyxiation typically occurs rapidly after allergen exposure, with death occurring within an hour in many of the cases. The severe bronchospasm during anaphylaxis characteristically develops in the individuals with pre-existing asthma. The evidence suggests that during anaphylaxis, the peripheral tissues continue to consume oxygen at relatively higher rates, and because of this, in combination with feral vasoconstriction and decreased perfusion occurs, and this leads to rapidly to anaerobic metabolism and end organ damage. When we find this kind of situation, then there are several differential diagnoses which comes to our mind, because sometimes it is very difficult to distinguish between those, especially with the asthma, syncope and panic attacks. Asthma, however, typically does not entail itching or GI symptoms. Syncope presents with the pallor rather than a rash, and a panic attack may have flushing but does not have hives. The management in such situation, because the anaphylaxis is a medical emergency which requires resuscitative measures immediately, such as airway management, supplemental oxygen therapy, large volumes of intravenous fluids, and of course the close monitoring of the victim. The administration of epinephrine is the treatment of choice, with antihistamines and steroids often used as adjuncts. Cause of death. In a case of death, what is the cause? Basically, it's the respiratory arrest and or shock with cardiovascular collapse are responsible for most fatalities. So basically, it's a combination of both. The cause of death appears to be determined, at least in part, by the type of allergen. In a study by Pumphrey and Roberts, in which they had 56 cases of fatal anaphylaxis, which they studied, all food-induced reactions involved difficulty in breathing, and a respiratory arrest was the cause of death in 13 out of 16 cases. In contrast, shock with respiratory compromise was the presentation in most cases of venom or medication-induced anaphylaxis. So it depends upon the type of allergen. This correlation between allergen type and mechanism of death has been noted in several other studies also. In a very small number of cases, massive epinephrine overdose or disseminated intravascular coagulation appear to be the immediate cause of death. At the time of autopsy, how to make a postmortem diagnosis in such situations? As we understand, the sudden anaphylactic deaths that occur outside hospital, sometimes in the emergency room or during medical treatment, usually they are subject to forensic autopsies. And these cases are a source of frustration to the forensic pathologist, because the diagnosis of anaphylactic shock is one of the exclusion and has been based solely on the circumstantial evidence. For example, in deaths immediately after ingestion of certain foods or after giving certain medications which are known to cause allergy, or even after sting bites. For example, wasp or honeybee stings. The diagnosis of fatal anaphylaxis is determined by the clinical presentation and historical information. The autopsy findings and laboratory testing may support the clinical impression, although they are not necessary or sufficient in isolation to make the diagnosis. In cases of sudden death of uncertain cause, femoral venous blood can be collected and the serum can be separated and frozen for the later analysis. The typical autopsy findings, what will be those? Many victims have no distinguishing gross pathological features at autopsy, particularly if shock develops rapidly. When present, however, the findings include the upper airway edema, mucus plugging, and the hyperinflation of the lungs as well as the cerebral edema. Again, in a series of 56 cases reviewed by the same author, Pumphrey and Roberts, all individuals collapsed after allergen exposure and 23 had a documented asthmatic component, although the dermatologic signs and symptoms were uncommon. But then he reported following gross findings in his series. In 41% of the cases, he found laryngeal or pharyngeal edema. So that is one of the very important findings, but provided the autopsy is done reasonably early period, say within 6 hours of the death. The hyperinflation of the lungs and or mucus plugging, they found in 27% of the cases. Again, in 27% cases, they found cerebral edema, which suggests cerebral hypoxia. In 18% cases, they found petechial hemorrhages in the mucosa of the airway, which suggested the asphyxiation. And the urticaria or cutaneous erythema was found in 5% of the cases. In another series review of 92 deaths which were reported from Ontario, Canada, the autopsies were performed in 65 of the documented deaths, that is around 71% of the cases were subjected for the medico-legal autopsies. And the most common reported findings on autopsy were 60% of the cases the pulmonary congestion and edema was found. In 46% cases the upper airway edema was found. The mucus plugging of bronchi and hyperinflation was found in 17% of the cases. The cerebral edema was found in 15% of the cases, whereas the congestion of liver and spleen as well as petechial hemorrhages was found in 14% cases each. The vomiting was a presenting feature in 8% of the cases. Then in another study, 30 venom related deaths, there is evidence of insect sting was found in the 12% of the cases in the same study. Severe edema was found in 46% of those with upper airway edema and 11% with lower airway findings. In cases where anaphylaxis to food is suspected at the time of death, the pathologist can be asked to preserve some of the stomach contents for later analysis for suspected food allergens. Thus, autopsy findings in suspected anaphylactic deaths are variable and appear to depend upon the type of allergen and the route of administration as well as the time between initiation of the allergic reaction and death. Then serum tests. Certain serum tests have been found useful. The blood is collected during or shortly after the event. They may be analyzed retrospectively for the mast cell derived mediator tryptase and for the evidence of IgE to the suspected allergens. Then histamine, serotonin and heparin, they are the substances which are stored in mast cells. So their physiological and biochemical effects have been known for a long time, and in vivo, that is meaning in laboratory, histamine has been used to indicate mast cell activation. However, histamine is rapidly metabolized during postmortem period. So the more recently characterized neutral proteases are more stable and have been reported to be located exclusively in mast cells and basophils. One of the neutral protease, that is tryptase, is the most abundant protein which is produced by the human mast cells and principally derived from the two genes on chromosomes 16p13.3, alpha tryptase and beta tryptase. Mature beta tryptase is stored in secretory granules as an enzymatically active tetramer in a complex with heparin proteoglycan until the cells are activated to degranulate and release the protease proteoglycan complex. So this alpha tryptase is the predominant form of tryptase detected in normal serum and is markedly elevated in patients with systemic mastocytosis. The release of beta tryptase into the circulation serves as a clinical marker of mast cell activation. So the tryptase is a mediator released by mast cells upon activation and is relatively specific to this particular cell type, although basophils also make a small amount of tryptase. Any elevation is consistent with the anaphylaxis. Tryptase levels that are within normal limits do not exclude the diagnosis. Tryptase is seldom elevated in food-induced anaphylaxis. So, if the fetal anaphylaxis due to food, we will not find any elevation in the level of tryptase. We must understand it is only in the basically in the bee sting type and others. The quantitative IgE immunoassays, they may be helpful in detecting the presence of allergen specific IgE in the victim serum as a means of confirming that the patient was allergic to that particular allergen in question. The serum IgE levels, they do not change substantially as a result of anaphylaxis. The positive test for allergen specific IgE suggests the presence of sensitization. However, the negative assays do not exclude sensitization. Again, in the same study by Pumphrey and Roberts, there were 50 cases in which this information was available. Of these, 21, 19 and 16 fatalities were respectively due to medication, insect venoms and food allergies. That means 21 were due to medications, 19 were due to insect venoms and 16 were due to food allergies. The laboratory test results were not available in most of the cases. However, in the 16 cases of fatal anaphylaxis due to a variety of agents in which tryptase level were measured, elevation were found in 14 cases. In a series of 25 selected cases of fatal anaphylaxis reviewed by Greenberger et al., they found the serum total tryptase concentrations were elevated in 4 of the 7 cases which were tested for that. Again, in a Canadian review of 92 deaths in 26 years from period 1986 to 2011 related to anaphylaxis, the causes of death in order of decreasing frequency include food, 40 cases. Interestingly, they found food is the maximum number of cases in contrast to the medications, followed by the insect venom, 30 cases, the iatrogenic, 16 cases and the idiopathic, 6 cases as they said. Overall, there appeared to be a decline in the frequency of food-related deaths, but an increase in iatrogenic causes of fatalities. They found factors associated with anaphylaxis as delayed epinephrine administration, asthma, allergy to the peanuts, the food ingestion outside the home, and teenagers with food allergies. In many cases of fatal anaphylaxis, no specific findings are present at autopsy. This is particularly likely after reactions that caused rapid onset of shock. In the presence of a typical history, the absence of specific findings at autopsy does not exclude the diagnosis of anaphylaxis. The tests for specific IgE and mast cell tryptase might help to determine whether anaphylaxis is the cause of death, but are not often used. These tests should be performed in all cases with a suggestive clinical history and no specific findings at autopsy. Further, the possibility of anaphylaxis should also be considered in all cases of sudden unexpected death with absent postmortem findings. And all such cases, the femoral vein blood should be sampled and then separated, serum frozen, and then so that afterwards the specific testing of IgE antibodies and mast cell tryptase can be done. The result of these assays should be interpreted in the context of the clinical history and the postmortem findings. Postmortem diagnosis of anaphylactic death is very difficult, and it is only possible after excluding every other cause of death. The diagnosis of fetal anaphylaxis is based upon clinical course and proper history supported by the laboratory as well as the autopsy findings. The femoral venous blood can be collected and the serum is separated and frozen for the analysis or assays of tryptase and allergen specific IgE. The victims of fetal anaphylaxis may show no distinguishing gross pathology features at autopsy, possibly because death can ensue so rapidly. And in the presence of a typical clinical history, absence of postmortem finding does not exclude the diagnosis of anaphylaxis. To summarize, anaphylaxis is a rapid onset, potentially life-threatening, systemic allergic reaction that can affect people of any age or sex. Fatal anaphylaxis can occur following a variety of triggers, although the most common culprits are medication, food and insect stings. Adolescent and young adults are at high risk for fetal anaphylaxis induced by the food. The postmortem diagnosis of anaphylaxis is very difficult and only possible after excluding other causes and obtaining the clear-cut history. Histamine, serotonin and tryptase estimations are very much helpful in confirmation of anaphylactic death. The quantitative IgE immunoassays may be helpful in detecting the presence of allergen specific IgE in the victim serum as a means of confirming that the patient was to the allergen in question.